Hello.
Yes.
Yeah. Dr. Sedonia, good evening.
Good evening. Thank you very much. So please hand over the mic to our special guests of honor for today, the multi-talented, ever-brilliant Dr. Juvesius Atta, specialist obstetrician gynecologist. Over to you, Juve.
Okay, so please, can you see my screen?
Yes, I can see it.
And please, can you hear me?
Yes, loud and clear.
Okay, all right. So thank you very much for this opportunity. And I'm also grateful to the guests, all those who have tuned into this moment. Unfortunately, I'm not in the best of mood because my goat is out of the competition. However, I would have to do what I would have to do. I'll muster courage. We move on. So welcome. I thank you once again, and also I welcome all those who have joined us live. Today we are going to discuss cesarean section. I hope that within 15-20 minutes I'll be able to conclude my slides. I have just about 17 slides or 16 slides. Once that is done, I'll invite questions. So my name is Dr. Juvesius Atta. I'm an obstetrician and gynecologist in the Central Region. And for today, this is my objective. Is a single objective: to demystify cesarean section, especially for those who are not clinicians or are not medical professionals, so that they can also appreciate what cesarean section is all about, and probably try to address some of the myths and then frequently asked questions to help them appreciate what cesarean section is about, what goes into it, what is done, and the possible complications, why it needs to be done, and why we do not have to do it excessively. So that's the objective. By way of outline, I'll introduce us to it. I'll give us the indications, some of the reasons why we do cesarean section for patients, and then some of the complications that can arise from the procedure itself. Address some myths, and also try to answer some frequently asked questions, most of which will be answered by the presentation itself. So what is cesarean section? It's simply a surgical procedure used to deliver a baby from the patient's womb or the uterus. Normally, when a woman is pregnant, we expect that at the end of 9 months, she'll go into labor, push the baby through the vagina. And that's let me say, the ideal situation. However, life is not perfect. So things always do not go as planned. And certain times the doctor will determine that if we allow this pregnancy or this labor process to go through, we may lose the mother, or we may lose the baby, or we may have complications that will not be beneficial to either the mother or the baby. And for that matter, we need to intervene. So that's what cesarean section does, just that. So as by way of the procedure itself, it means the doctor will cut into the woman's abdomen and also cut into the woman's uterus, bring the baby out, close the wound that he has caused on the uterus, close the wound that he has caused on the abdomen, and then manage the mother through and hope that, not hope, but ensure that the mother at the end of the day is safe and the baby is also safe. Worldwide, as of 2018, when you consider every 4 women who have delivered a baby, 1 of them had a cesarean section. Now this is quite high. It means that every woman, or amongst all women that go into labor or deliver a baby, 1 out of 4 of them would have had a cesarean section. When you compare that to the 1990s, where the rate was about 1 in 15, you realize that over the years, there has been this marked increase in the rate of cesarean section. And one of the main reasons why cesarean section has gone up is the issue of maternal requests. So these days, you would have a woman walk into the consulting room, not delivered before, but already will tell you, doctor, I want to have a cesarean section rather than deliver. And it's usually mostly associated with some of these myths that are out there. People thinking that cesarean section is a better option than vaginal delivery. So at this point, I would like to make a categorical statement that by all means, if achievable, vaginal birth is the better option. and I'll give my reasons later. But where indicated, you cannot compel a woman to have vaginal birth at all costs. So that's where we have to draw the line. Cesarean section has its place, but it must be done at the right time. When you come to sub-Saharan African countries, interestingly, the rates are lower. In Ghana, as of 2015, from the Ghana Maternal Health Survey, the rate is about 13%. It means that of every 100 women who delivered, 13 of them had a cesarean section. So compared to what we have globally, it was better in 2015. We're even meeting the WHO target. But I realized that even for Ghana, as of 2018, from the 2017 Maternal Health Survey, the Ghana Statistical Service reported that the rate had increased from 13% to 16% over the 3-year period. So then you get to, well, even in Ghana, the rate is going high. And as of now, with the 16%, we are above the WHO threshold of 15%. Now, why would WHO say that there shouldn't be more than 15% cesarean section rate? Because it's been found that even though cesarean section is beneficial, once you exceed that rate, the benefits are actually not seen. I mean, it's not so clear, it's not so obvious, and rather you have complications. The complications for the parents or the mothers actually go up, even for the baby. So above that threshold, cesarean section doesn't seem to offer any benefits at all to the mother or the baby. So for indications, as you can see, it's basically 3 things that we hope to achieve. 2 things: to save the mother and to save the baby. But you look at the triangle in the middle, and I've said for non-medical reasons. One common one is a mother requesting for cesarean section. So, okay, I want to have a cesarean section, but there's no real medical or clinical indication for the procedure, and it becomes a difficult issue. However, because the woman has a say in her own health and what intervention she wants to get, there is still room for counseling her. And if after counseling her, she still opts for the cesarean section, then the clinician may have no option than to provide it for her, the service for her, as that is her request. It's actually an area of which has ethical implications that must be looked at carefully, but it's rising. And in the United States, about 7% of their cesarean sections are actually due to maternal requests. So that's quite significantly high. I don't have the figure for Ghana, but to save the mother, we want to prevent maternal mortality. So if we think that the mother going on with the labor, at this point, we determine that it is detrimental to her health, we would like to offer her a cesarean section. Currently, the maternal mortality rate for Ghana from the Ghana Maternal Health Survey of 2017 is 310 per every 100,000 live birth. Now, according to the SDGs, we are hoping to achieve rates lower than 70 per 100,000 live births. So if we have interventions that we know can help improve these values, then we have to put them in place. And one of them is cesarean section. Also, is where the baby's life we consider to be under threat, or the baby's well-being we consider to be under threat. If we allow the mother to go through the labor process, we'll also offer a cesarean section for the mother. At the end of it all, anytime a woman is pregnant, this is what we want to achieve. A live baby, not just alive, but healthy baby to a happy mother. I added this picture just so I'm not tagged as being racist. So the first one was black, but the second one, you can see this is a white woman and her happy with her baby. But even more, we would love to achieve this, where beyond just the mother and the baby, the family of the mother and the family of the baby are equally happy, starting with the husband in the nuclear setting, and even for the extended setting. It's always catastrophic when a woman gets pregnant, is expecting to deliver and loses the baby, or when a family have a woman pregnant, expecting that she'll go through labor process and add on to the members of the family and also the society at large. For them to lose the mother, it's usually catastrophic. And this is something that we hope to avoid. And if at any point now we determine that cesarean section is necessary to do this, then that's what we are going to offer, and we hope that the patient will listen and agree with us. Now, so basically I said that we do cesarean section to save the mother's life when needed, or improve the mother's health when needed, and also save the baby when needed, or improve the baby's outcome when needed. But these are some common medical jargons. I've tried to, as much as possible, avoid medical jargons in this presentation because of the target audience, or the audience that I have. But these are certain indications that you would see. Maybe if you've had a relative who has had a cesarean section, or probably you yourself, or maybe your wife or your partner goes into labor. These are some jargons that may come along the way, that the doctor will probably table to you and say, for this reason, I would like to offer a cesarean section. Fetal distress simply means that the baby is not doing well. So usually when a woman is in labor, we put the woman on the pathograph, more like a graphical thing that we use to monitor the progress of labor. And on it, we have things that we document to determine how well the baby is doing. One of it is the fetal heart rate, or the baby's heart. So if at any point in time, the doctor or the attending team realize that the baby's heart is too low or too high, the heart rate is too low or too high, it may signify that the baby is not doing well in the womb. And if it is too far away, or it's going to take a long time before the woman delivers, the doctor will say, okay, let's throw in the towel, let's have a cesarean section for you. The phallopelvic disproportion simply means, if you look at the image, you realize that there is a baby going through the mother's pelvis. The head must traverse the mother's pelvic cavity for it to come out. Often than not, this is how the baby comes during delivery. Sometimes the baby may be coming with the buttocks, but often than not, the baby comes with the head. So assuming the baby's head is too big to pass through that cavity, or sometimes the mother's pelvic cavity is too narrow for the baby's head to go through, it will give evidence of it clinically. And based on examination, the doctor can tell that there is the head size and the mother's pelvic cavity diameter is not proportionate. So then we need to offer cesarean section. Now you can guess what will happen if we make a woman labor in that scenario. Definitely the baby will not be able to come out. The uterus will be contracting. And what everyone fears might happen. The first thing that will happen is that there will be what we call obstructed labor. And if still we don't intervene, the uterus will rupture. Literally, it will burst like a balloon burst, and the baby will come out, we'll lose the baby. And in that setting, often and not about 10% of the mothers who experience uterine rupture, we also lose the mothers. So it's not something we would like to encounter. The other thing, prolonged labor simply means that the woman is in labor, but it has dragged beyond the expected time. If the doctor assesses and realizes that the reasons for this prolongation of the labor, the reason for this prolongation of labor is not something that we can overcome, then definitely we need to still have a cesarean section for the patient. When a woman goes into labor, we expect that usually within 12 to 18 hours, the woman would have delivered. But when the woman is in what we call active phase of labor, we expect that within 6 to 9 hours, the woman should be able to deliver because of the rate at which the cervix opens up. Another common reason for cesarean section is that those who have already had a cesarean section, the chance that they will have another cesarean section is high. Then again, I mentioned the maternal request. And then more presentation simply means that the baby may not be coming with the head, but the buttocks. Or sometimes the baby will be coming with the shoulder rather entering the pelvic cavity, what we call the transverse slide. In that scenario, there is no way the mother can push the baby through. For the when coming with the buttocks, we call it the breech presentation. For that one, depending on how the woman is presenting, sometimes we can allow the woman to deliver per vagina. Other times there may be a need to intervene surgically. Antepartum hemorrhage is simply woman bleeding from the vagina or the genital tract before the baby comes out, whether the woman is in labor or the woman is not in labor. Once she bleeds before the baby comes out, we call it antepartum hemorrhage. Commonly, we have it, what you may hear what we call, or what the doctors or the clinicians will term as placenta previa or placenta abruptio, commonly in the corridors of the labor ward. That's just what it means. So what's the process that goes in when we are going to have a cesarean section? Of course, the first thing is to speak to you. The doctor will tell you why there is a need for the cesarean section by way of counseling, let you appreciate what the benefits will be, what the likely complications are, and ask you to consent to the procedure once you understand him or her clearly and you understand the benefits to you. Then you sign, the patient will sign a consent, an informed consent, to give a consent to the procedure, meaning that the doctor cannot force his opinion or his clinical decision onto the patient. Next, there's what we call the pre-procedure preparation. We'll do some blood workup to know what your blood level is, your blood group, get some blood in store for you in case you bleed excessively. Then they'll give you some IV fluids to make sure that your vascular space, it contains enough blood. Because during the process itself, you are going to lose some blood. So by giving you IV fluid, it dilutes your blood. Make sure that when you lose blood, you don't even lose too much hemoglobin and you don't go into shock easily. Then we'll gather the materials that are needed, including the theater, the anesthesia, equipment, the things needed to resuscitate the baby, and also the instruments that will be needed to perform the operation will be gathered. Then we move the woman to the theater. In the operating room, we give anesthesia so that the woman will not experience any pain. And anesthesia, we have two types, what we call the regional anesthesia and then the general anesthesia. For the regional anesthesia, usually the doctor will, or the anesthetist will inject something at the back, lower back of the woman to numb the part from the abdomen down to the leg so that even when the doctor makes a surgical cut, the patient will not feel the pain. And because it is just regional, the patient will still be awake. And even after delivering the baby, the patient will be able to see a baby and the baby can be given, where she can even hug the baby at that point because she's not really asleep. But under certain circumstances, there is the need to make the patient sleep, especially when the patient is bleeding, because the anesthesia that we give to the back of the patient, sometimes it can drop the blood pressure, and with the patient bleeding as well, it is not reasonable to do that particular anesthesia. So there may be the need to put the woman to sleep for that purpose. Then we'll clean the skin with an antiseptic solution, and then anesthetist also give you an antibiotic. This is to prevent infection after the procedure. Then we'll drape the patient nicely, and the doctor will now cut the abdomen, separate the muscles, enter the abdominal cavity. We'll use something to retract the bladder away, use something to push any bowel in the field away, make a cut on the uterus or the womb, bring the baby out, remove the placenta, close the womb nicely. If there's any bleeding, we will secure the bleeding points to ensure the woman does not bleed excessively, and then close the abdomen. That's all that goes on there. Now, by way of complications, there is no procedure or surgical procedure in the world that does not have complications. And cesarean section being one of the commonly done or practiced surgical procedures is also associated with some complications that you need to know, starting with the anesthesia that will be given to you itself. Now, before I go on, let me say that I'm not saying this to scare anyone away from cesarean section. It's just to help you be informed about the possible complications so that it does not come as a surprise. In fact, before any cesarean section, the doctor will still give you this information. But always, we try to because medicine has advanced, surgical practice has advanced to the point where we are able to put measures in place to minimize these complications from happening as much as possible. For anesthesia, sometimes your blood pressure can go down, which is the major problem. Sometimes even after the procedure, some of them will be complaining of headaches if they have the spinal anesthesia that I explained. Also, definitely the doctor is cutting the skin, cutting the uterus. Definitely it will open up bleeding points. Anytime there's a cut, there is bleeding. So the patient can bleed. And sometimes this bleeding may be excessive and may need to be control. Sometimes there's even the need to transfuse the woman while the procedure is going on because of excessive bleeding. Now, behind the womb or behind the uterus, your internal organs are there. That is the intestines. And in front of the uterus, your bladder is also there. To the sides of the uterus also, the ureter that connects your bladder to the kidney also runs through some structures in there. So all these structures, because it's a surgical procedure, can be damaged. But the risk of this damage is less than 1%, meaning when you take 100, you operate on 100 women, less than one of them will get some of these complications. So it's not that common. And also because of the advancement in surgical practice, we are able to retract the bladder away, we push the intestines away to minimize this from occurring. And because there's also a wound is being created, if we don't put measures in place, there can be an infection, especially those that go into labor before the cesarean section. But that's why we clean the skin very well and we give antibiotics and sometimes even continue with the antibiotics after the operation. Then there may be the need to remove the uterus. That only comes in when the woman is bleeding excessively, or sometimes the placenta or the, I'm sure we are, if you don't know what the placenta is, after the baby comes out, the cord connects from the baby to some structure or tissue. That tissue is attached to the womb. That is where the baby was getting its nutrients from. So that placenta must come out, but sometimes it is too, what we say, morbidly adhered so much that it cannot come out. For that reason, we may need to do a cesarean a hysterectomy. That is, remove the entire womb of the woman. So that's also a possibility, and you must know this, but it's not something that happens very frequently. Then the issue is that once you have had a cesarean section, it also increases your chance of having another cesarean section in your next delivery. Venous thromboembolism is when clots form in your leg or the veins of your leg or the veins, deep veins of your body, and these clots can be thrown and get into your lungs and can cause problems. Because of that, we make sure that the surgery does not delay. We also use something we call test stockings, and when the woman has an increased risk, we give her even some medications during the procedure and through, even after the procedure, to ensure that this does not occur. So it also doesn't occur quite often. Now the question is cesarean section or vaginal birth, which is better? And I'm asking you, my audience, what do you think? I'll just put it in plain terms. By reasonably, if God made human beings to deliver per vagina, then definitely vaginal birth, if achievable, is the best. So the key word is if, or the key phrase is if achievable. So if achievable, we all agree that vaginal birth is the best. But where allowing that process to go on will be detrimental to the mother or the baby, it will be quite inhumane to offer her an option that relieves her or the baby. So in that setting where cesarean section is indicated, then cesarean section becomes the better option. So it's not a yes or no answer. It's an issue of the clinical scenario that we are dealing with, the mother, the baby, and the labor process, what is going on and what is best for the woman at that point in time. And by this, I don't want people to be afraid of cesarean section because I'm saying vaginal birth is the best, so that when the doctor says, oh, let's have a cesarean section, then you begin to have issues or bear qualms with the doctor. Again, I also don't want to say that because cesarean section offers some advantages, then you should always go forward requesting for cesarean section. So we have to create that balance, and it must always be a discussion between you and your clinician. Some of the myths around is that cesarean section is a death trap. You see, this used to be something of the, it was in, cesarean section has gone through a lot of transformation over a century since it was practiced. So there's been so much advancement. Those days where a woman goes to theater and does not return, it's no more. In fact, it is now quite rare. It's quite rare. Where I practiced in the past 1 year, we've not had any death from maternal causes, also not from cesarean section. So it is not a death trap at all. Rather, when indicated, it's a very, very needed procedure that saves the life of the mother and or the baby. cesarean section is easier than vaginal birth. Well, technically, no, it's not true. Actually, it may seem so because cesarean section can be carried out within 30 minutes. Within 30 minutes, the procedure is done. Sometimes it can extend to 45 minutes. And because of the short duration of the process itself, it may look like it is easy, but it is not easy because you need someone who can do it who is competent and also hope that the anatomy of the mother and every other thing goes on as planned. Otherwise, it becomes a very difficult surgery. It's not as simple as that because now it is very frequently done. It gives the impression that it is easier. It's not easier than vaginal birth. In fact, vaginal birth is easier. CS will reduce the risk of prolapse. Prolapse happens especially to women who have had so many pregnancies. So it's like after pregnancy, after delivery, and even with aging, the structures that hold the uterus together, they become weaker. And as they become weaker, the uterus begins to push through the vagina. And because the labor process itself sometimes aids in the weakening of these structures, it is thought that then cesarean section can reduce that risk. But let's remember that the risks that predispose to prolapse are numerous. Sometimes the work of the person, what the person does, the fact that she has been pregnant so many times, even aging process itself can bring that. So when you weigh the risk against benefits, it is never reasonable, considering all the possible complications that can happen with cesarean section, to have cesarean section simply because you want to avoid a prolapse, a uterovaginal prolapse. Cesarean section will keep the vagina tight. I don't want to argue on this one. I'll leave it as it is. But if you think that, considering all the risk associated with cesarean section, if you can deliver vaginally and you just want to keep the vagina tight, because of that, you want to go and have a cesarean section, remember, it's a risk to your own self. Some of the women do it for their spouses, so that their spouses will not cheat. I'm not going to say whether it is going to work or not, whether the tightness of the vagina reduces the risk of cheating, but all I'm going to say is that if you consider the risk associated with cesarean section, it is not worth it going to do a cesarean section simply because of vaginal tightness. If later your vagina is lax and you want to make it tight, you can speak to an obstetrician or gynecology for the way forward. Exercises can be done, sometimes even surgical procedures, which are less risky than cesarean section, can be done to narrow this vagina introitus for you. So that's all I can say with respect to that. Doctors are paid more to do cesarean section. Some people think doctors are doing so many cesarean sections because they get more money from it. I can tell you specifically from where I work, because I work in a government facility, and other government facilities that I have worked, doctors are not paid any extra incentive for doing cesarean section. Well, at least from where I work, I don't receive any extra incentive for doing cesarean section. So it does not, financial gains do not influence my decision to offer a woman cesarean section or not. A mother cannot have a vaginal birth after cesarean section. And that is not true. Back in 1916, Kragen postulated a statement that once a cesarean section, always a cesarean section. That was because after cesarean section, usually the scar is weak, so there was an increased risk of uterine rupture, and the mortality rate was about 10%. So it became very difficult allowing a woman who has done a cesarean section to have another cesarean section. But over the years, we realized that, yes, even though some people have had cesarean section, they can still have vaginal birth, especially if she has had only one cesarean section. But we carefully select the patient. I'm not saying that every woman who has had a previous cesarean section can have vaginal birth. All I'm saying is that if you've had one previous cesarean section, we can weigh the risk, assess you, and if we determine that all the parameters that need to be fulfilled for us to give you a trial of labor have been fulfilled, we can still offer you vaginal birth. However, in Ghana, if you have more than one cesarean section, that is 2 or more cesarean sections, we definitely will offer you a repeat cesarean section for the very reason that the risk of rupture is about 2%. It means that for people who have had 2 cesarean sections, if you allow them to labor, 100 of them go into labor, 2 of them will rupture. Now that 2 of them is significant. Not less than, once it's not less than 1%, it becomes a common occurrence. And if it happens, it's a 100% scenario for that individual. And as I said, if 10 people rupture, 1 will lose their life. So we will not consider that 2% risk. In Ghana, elsewhere where they have other facilities, even for those who have done 2 previous cesarean sections, they can give them a trial of labor, give them one-to-one nursing, continuous monitoring on CTG. Some of these facilities, we don't have them readily available in our settings, so we have to practice our medicine or our obstetrics contextually and in the context of our locality, our setting. Anyone who has a 2 or more previous cesarean section will offer a cesarean section for. A mother cannot have vaginal birth after cesarean section. So I've addressed that one. God wants every woman to deliver at all costs per vagina. This is something that I've heard before. And this is where pastors come in and even doctors in the homes. Sometimes they push so much information into the patient's head. You must deliver at all costs. Some will even come to the labor ward with anointing oil. There was this one time this woman came, she had a 2 previous cesarean section. Even the scan said the baby was too big, 4 kg. We told her you can't deliver per vagina, but she was holding anointing oil. She will not allow us to do the cesarean section. This woman ruptured the uterus, lost the baby, but we were able to save her life. At the end of the day, who benefited, the pastor or not? We always have to remember that it is the same God who gave us humans the knowledge and wisdom to anticipate, be able to diagnose some of these conditions and offer solutions. So no, it is not that God says you must deliver the vagina at all costs. Sometimes it will be at a grave risk to you if you denied the cesarean section. Frequently asked questions, what is cesarean section? I've explained that already. What is emergency cesarean section? So there are 2 types of cesarean section. One main, that's in broad category. One where we have determined that the woman is in labor, but along the way we've determined that it will be detrimental to her or the baby. In that setting, it becomes an emergency. Sometimes the woman is not even in labor, but there is a condition. For example, if the woman has had a seizure because of the pregnancy, we want the woman to deliver within the next 8 hours. But if we check the vagina and realize that the vagina is not even favorable, the cervix is not favorable, allowing her to progress becomes dangerous to the woman. So it will also be an emergency in that setting, even though the woman is not in labor. Then we have what we call elective cesarean section or planned cesarean section. So that one, even before the woman goes into labor, we have had a discussion with the woman and we have long determined that based on 1 or 2 reasons, the moment you go into labor, there will be trouble. For example, someone who has had 2 previous cesarean sections, we can't allow her to get to the time to deliver per vagina. So that's why we plan it ahead of time. And it's been determined that people who have planned cesarean section is usually a bit more safer compared to the emergency one for obvious reasons. What happens during cesarean section, I've explained it. Will I be awake during cesarean section? So as I said, if you had a regional anesthesia or what we call spinal anesthesia, then yes, sometimes it's even an epidural anesthesia, then yes, you'll be awake, so you'll be able to see your baby. But if it's a general anesthesia, we put you to sleep, so you will only be able to see the baby after the cesarean section. How long does a cesarean section take? Usually anything between 30 to 45 minutes, the procedure will be done. Sometimes some surgeons are faster, but what is recommended is to be able to do it within 30 to 45 minutes to minimize the risk of mistakes at surgery, and also not to prolong the surgery too much so that you don't increase the risk of an infection and venous thromboembolism. Those are the reasons. Why would an emergency C-section be delayed? Sometimes someone will say, oh, I went to Kolebu, the doctor said I needed surgery, but they let me lie down before they did the surgery. What I'm saying is a practical scenario, which happens. Even in my facility, sometimes it happens. We've diagnosed that the woman is an emergency cesarean section, but for 1 or 2 reasons, simply we can't do it at that moment, so we delay it a bit. It doesn't mean that the doctor or the nurse does not care about you. It's just the prevailing circumstances. For example, in Kolebu, they can do over 20 cesarean sections in a day. Imagine that 2/3 of them are emergencies. Just imagine, one goes in, when will you have yours? So sometimes it's because of resource constraints, which may be human resource or the resources needed to carry out the procedure, or it's usually a good reason that dictates that even though we've diagnosed emergency CS, it delays. It's not because the attending team does not care about the patient. And I hold my baby immediately after C-section. Yes, usually for those awake, even when we deliver, we place them on their chest or their torso, and we encourage them to even touch them and hold them and see them, and we show it to them. So it doesn't mean you will not be able to hold your baby. In fact, after the procedure, you'll be able to carry your baby and have good time with your baby. So yes, that is yes. Can I breastfeed after cesarean section? Of course, you can breastfeed after cesarean section. There's no difference between delivering per vagina and cesarean section as far as breastfeeding is concerned. And this is where I'll bring a pause to my presentation, and I'll invite questions from you. Thank you very much for listening.
Thank you very much, Dr. Juventus Arthur. That was very, very, very extensive. And you've answered, just like you said from the beginning, you literally answered all the questions that may possibly come. But at this point, if anybody has any question, please feel free, put in a chat box in the comment section. I will read it out. Dr. Arthur will answer it for us. Thank you very much, Dr. Juventus. Now, I just have a question to ask. Doc, after 3 cesarean sections, is it safe for the woman to have a 4th one?
Okay, so this is a very, very good question. I was expecting it to come up. I intentionally left it so it comes up. The question is, how many cesarean sections are safe, or can a woman have? And often than not, you hear someone that, oh, after 3 cesarean sections, and sometimes it's not even the patient, it's the clinicians ourselves who propagate this information, that once you've had 3 cesarean sections, madam, let us tie your womb, let us give you a BTLO. Technically speaking, there is no limit to how many cesarean sections a patient can have, because there is no research that categorically states or puts a threshold on the number of cesarean sections a patient can have. Now, that is not to say that a patient can have so many by choice, but it is determined by the patient herself and her condition. So we say a patient can have as many cesarean sections as is safe for that patient. So it's individualized. It means if you've had 5 cesarean sections and I'm having another one for you, and I realize that even after 5 cesarean sections, based on the previous operations, the uterus is still good, the lower segment is still thick enough, the wound is okay, there are no adhesions. It means that even at your next cesarean section, it's not going to pose significant complications. Yes, we can still give you the chance to go ahead. But sometimes when we enter the theater, we look at it, sometimes even just after 1 cesarean section, what you go and meet in there, you always advise the woman that, look, if you are going to have another pregnancy, it should be when you are ready to face all the risk and you really need it. So it depends. There is no threshold as far as that is concerned.
Okay, again, just pushing the limit. What would you advise is the safest number of CS a woman should have if you are given the option as an expert to advise a woman?
For me, as an expert, I would always manage the patient. It's not really going to be different from the first answer that I gave, because I'll manage the patient. It's always about the patient.
All right.
For example, if a patient is has sickle cell disease,
yes,
with every pregnancy, the patient will have crisis. So after 3 cesarean sections, why would I let you have another cesarean section? Or right. I go in there into your womb. I realized that there are a lot of adhesions. The placenta was morbidly adhered, but not to the extent that we couldn't bring it out. So even after bringing the placenta out, we struggled to secure hemostasis. Again, for you, that particular woman, I'll not advise you to have another cesarean section. So it doesn't really change. I know you were trying to twist the question, very intelligent of you, but it doesn't really change. It's still patient specific. So I always say that every cesarean section is a risk. So you as the patient determine first how many children you want to have. Because even not just the risk associated with pregnancy and delivery, it's not just about the cesarean section itself, but even the pregnancy itself. Yeah. Each pregnancy is a different scenario. And pregnancies kill more patients. Imagine in Ghana, after every 100,000 live births, 300 lose their lives, 310. So pregnancy itself is a very high risk, and you must determine first how many you want to have before we even talk about the cesarean. But the cesarean will depend on what we meet at that point in time. I will still not give a straight categorical answer to that.
All right, there are some questions in the chat box, but before then, let me ask another question in the same vein. What is it that, with all things being equal, the surgeon, the specialist, does operational, when the person is operating on the patient, what is done to ensure that the subsequent ones don't face complications? Like you said, when you open up, you see adhesions, you see there are things. Mm-hmm. Are there things specifically done to hope that the next ones are
So one of them, the most important thing is the first step. And the first step is the cesarean section indicated? Yeah. Remember when I gave the reasons we do cesarean section, I put a triangle there. Yes. And I said those ones, non-medical reasons. So the first now advice is never to do a cesarean section for non-medical reasons, unless the patient pushes for it. So if it is not indicated, don't do it, because that's the first step to preventing this one. The second one is that once the patient is in theater, as you asked, the surgeon is in theater, in the woman's abdomen, as you asked, before the cut, we give antibiotics, because if the wound is infected and also the wound on the uterus is infected, it will not heal well. So it will not achieve good scar integrity, and that increases the risk of rupture later. So by giving antibiotics before the procedure, cleaning the skin very well before the procedure to minimize infection is one of the things we do to prevent the wound from having a weak or not having good integrity. Secondly, once it's in there, the surgeon must try to be as fast as possible. So you don't delay the procedure. That's why usually for someone to do CS on his own, he must be trained very, very well. And someone must certify that he is skilled enough to do it. That's not to say that even the experts do not run into trouble when doing cesarean section. I'm just saying that the risk is lower when you have someone who can really do cesarean section doing it. So the skill of the surgeon, being able to do it very fast to prevent the risk of infection. Then to minimize adhesions, sometimes if the patient can afford, and you can keep the wound very moist, the surgical site moist, not to get it dry. But there's also some material that we can use to coat it. One common one is what we call high hyaluronic acid gel. It's not that expensive, even though it may be costly. I think it's around 300 Ghana cedis, you get one. And I encourage all my patients to get it if they can afford. Because when you apply it later, they don't develop these adhesions. So, and intra-op also, there are certain steps we take. For example, you have to retract the bladder away. You have to make sure that there is no intestine in your field so that you don't end up damaging these structures. Again, if the woman is, for example, obese, then you have to make sure that after the surgery or during the surgery itself, the woman is in some stockings to reduce the risk of DVT. After the surgery, the woman is put on Clexane to minimize the risk of DVT. I know you asked specifically concerning subsequent delivery, but I'm trying to add other information to let you know some of the precautions that we put in place to avoid most of the complications that we encounter.
Yeah, thank you very much. In fact, it's one of the reasons why we always need to hear from the experts themselves. Thank you very much, Dr. Arthur. Now, there are a lot of questions in the chat, but one of them is saying, is maternal request an indication for CS where you work, i.e. public facilities?
Yeah, so the principles of medical practice, you always treat the patient with dignity, respect, and you respect the patient having autonomous decisions over her body. It's her body. So you do not do things for the patient that she doesn't want. But as I said earlier, it's an ethical dilemma. Some people will say, I won't do it. But if you've counseled the patient properly, the patient is educated, you've counseled her properly, and made sure that she understood the things that you said. And upon all these, she still insists. So the issue is informed consent. She still insists that, doctor, I've heard you. You've told me about all the possible complications. I know what the risks are. You have to make sure she understands. Also, in the medical plan, there's something can she, her capacity to give the informed consent, you must also assess. Do you understand? If all these are in place and she still insists that I want to have a cesarean section, at our facility, yes, we grant it to them. We grant it to them. The only thing that sometimes it comes with an extra, because it is something we try to use to deter them. However, we still grant it to them because it's the patient's decision and we have gone through the counseling process. If I cannot do it or I am unwilling to do it, I must not deny her choice. The worst I can do or the least I can do is refer her to another facility or another individual capable of doing a cesarean is also willing to do it on that account.
All right. The next question is, how long does it take after a cesarean section for the couple to engage in sex?
Okay, so that's a very interesting question. To begin with, usually after cesarean section, 3 days after cesarean section, we discharge most of them. Sometimes even 2 days after cesarean section, we discharge them home. The pregnancy labor process, kush usually minimizes. So it's like you've come home. Papa is also there to satisfy himself. But it's a very, very intelligent question. I thank the one who asked the question. There's, most of the times we have to consider wound healing first. And it takes about 1 week for the skin. Usually by three days, the skin has opposed. If it's incision. Then about 1 week, the wound is usually healed, but not complete integrity. So usually advising that all things being, wait till at least after 2 weeks. However, I must add that it takes about 6 weeks for the woman to return to complete her pre-pregnancy status. Because pregnancy itself is we don't like to, sometimes we say it's an abnormal, it's normal, but abnormalities to it because normally people are not working pregnant. So after 6 weeks, yeah, the woman can usually engage, but after 2, the wound has healed very well and she's comfortable. The woman is comfortable engaging in sex. She can engage in sex unless there are other reasons that prevents her. Sometimes they may have had an episiotomy during labor or they may have had a tear or some sort of thing. So that's why you have to wait till there's complete healing and the woman can have sex.
Okay, then the next question is, does vaginal birth really loosen the vagina?
Yes, it is obviously. Usually, if you know, before a woman delivers, the vagina usually can admit like 3 fingers, or sometimes we say 2 fingers is okay. But with delivery, remember, if you can imagine the size of the baby's head, the diameter is about 10 cm. 10 cm is a bit bigger than your fist when you make a fist. So that head will come through. A baby weighing 3.5 kg is going through the vagina. And as long as that stretches the tissues, and anytime tissues are stretched, they do not return to the original integrity. So 1 bed, 2 bed, yes, it loosens the vagina. But even sexual intercourse alone also loosens the vagina. Of course, the vagina of a virgin is not like someone who has been having sex for a long time. So yes, the answer is it does. But is it good enough reason to say let's subject the woman to all the other risks compared to just vagina relaxing? That's the question we must ask ourselves.
All right. Thank you very much. Please, if you have any question, please put it in the chat box in the comment section. I'll read for Dr. Arthur to answer for us as he is doing very brilliantly. There's another question from YouTube. The young lady is asking, can fibroid be removed during CS?
Abi, I think I like your audience, but I don't know if they are clinicians themselves. Or they are really asking mind-stimulating questions we ask ourselves. It's another controversial area because during pregnancy, the uterus stretches very wide. I mean, you have a lot of blood passing through the uterus when the woman is pregnant. And at that point, remember that because of the placenta invading the womb, it converts some of the vessels in the womb to what we call capacitance vessels, so they become wider. And that is why usually after delivery is contraction that secures the hemostasis. What I mean is that it's a contraction of the womb on the vessels that reduces the bleeding. So the uterus at that point is very engorged, very vascular, a lot of blood running through it. And removing fibroids is associated with blood loss. Delivering the baby is associated with blood loss. Removing fibroids is associated with blood loss. So the risk of having massive bleeding at that point is very high. And for that matter, most authorities do not recommend it. However, there's also a section of authorities who say that if you are confident or based on the skill of the surgeon may, and the key word is may, decide to plan it and remove it after, during, or after the cesarean section, or in the process of the cesarean section. So we call it cesarean myomectomy. But I can say that most authorities do not advise it, especially in the hands of people who have less expertise. If my professor decides to do it, I cannot go questioning my professor. But at this stage of my career and considering the risk, personally, I do not encourage it. However, depending on the position or the location of the fibroid, sometimes it is just not, you have no option than to remove it. For example, if the fibroid is located where you are going to make your cut to deliver the baby, then definitely you must remove that fibroid. Also, sometimes the fibroid is not in the body of the uterus. It is only attached to the surface of the uterus. So we call it the subserosal fibroid, and it can be pedunculated. Sometimes all you need to do is to clamp the stalk of it, cut it, tie it like you are tying anything, and bring. So that one does not pose the risk of bleeding. So what I'm saying is that for these, if you think that it is going to be invasive, you do not need to do it. But in the situation where it is in your way for you to deliver the baby, you must remove it. And in the situation where it is pedunculated and you can remove it without subjecting the woman to increased risk of significant bleeding, you can also remove it.
All right, thank you very much. You did great. You answered most of the questions, but however, there are a few people who may still have some questions. So we have a few minutes to go. If you have any questions, please put in the chat box in the comment section and Dr. Juve will gladly answer. It's been an interesting session. I'm getting some good feedback from our audience. There's a question: how many times does a client have to undergo myomectomy to consider total abdominal hysterectomy?
There is no such limit as to how many times she has to consider total abdominal hysterectomy. However, with regards to myomectomy, what I'll say is that myomectomy does not eliminate the risk of having recurrence of the fibroid. And indeed, honestly, if you want to really prevent recurrence of fibroid, then the go-to is hysterectomy. So, but again, as I'm sure later someone will come and do a presentation on fibroids, we have to realize that we don't go about removing all fibroids because fibroid is very common. I mean, about 20% of women of reproductive age have fibroids. So if we decide to remove all fibroids, then we are going to remove a lot of fibroids, and or decide to remove the uterus for the fibroid. But fibroid that is causing problems like bleeding, uncontrolled pain, sometimes giving issues with fertility, we advise that we remove. But the decision between hysterectomy and myomectomy, when a surgery is indicated, is mainly dependent, one, on the woman's fertility wishes, and two, the patient's choice. So we are saying that if surgery is indicated for fibroids, we can either do myomectomy or hysterectomy. But there is nothing like, oh, I've done 10 myomectomy, so let me do a hysterectomy. The most important question is, does the patient have any fertility wishes? Assuming the patient doesn't want to give birth or has completed a family, or this woman is like 50, 55 years, gone past menopause, and you say you are going to do myomectomy for her so that, or close to 40 years, close to menopause, you are going to do myomectomy for her so that she will get another fibroid, or even leave the womb there for other risks, is sometimes it's like you are not offering the best option to the patient. So it depends on the woman's wish and the woman's fertility, that's her fertility wishes and her preference of surgery. Otherwise, we can't say that after 3 myomectomies, hysterectomy, or any of such.
All right, thank you very much. This is again coming from me myself. With respect to, in quotes, tying the womb of the woman after a number of CS, that is the BTL. Some people come back and ask, Doc, is it possible for a reversal? What would you say?
Because these days knowledge is all over, I would not like to go ahead, or I would not like to cover information or hide information and I say it is not possible. BTL, yes, it's reversible. In fact, elsewhere, they are reversing BTL. But there are a few things that we need to consider. One, anytime there is a BTL, we have to consider it as a permanent method. That is very, very important. It is a permanent method. So the counseling must be very well done so that the woman doesn't even return to seek a reversal. Because even after reversal, the chances of conception is very, very low. In fact, in some centers, it never even happens. Then again, when they conceive, the risk of ectopic pregnancy is very high. So it is really not advisable to be opting for reversal of the bilateral tuber ligation. So the question is, can it be reversed? Yes, as for the reversal, it can be done because we severed, cut it, and we separated it. It can be rejoined, but the question is, after rejoining, can the woman conceive? The answer is the chance is very, very low. After that, even if she gets pregnant, what is the likelihood that it will be an ectopic? Very, very high, over 80%. So it's not something that we advise. And that's why the counseling before offering the BTL is very, very important for the woman to know that it is intended to be a permanent method.
All right, so there's a question I have to just ask you. From YouTube, can one still menstruate after the uterus is removed?
Technically speaking, no. If you said you removed the uterus, then the person should not be able to menstruate, because for you to be able to menstruate, you need your brain function, because there's a part of the brain called the hypothalamus that releases certain substances. You need it to be functional. You also need your ovaries, that which lays eggs, to be functioning well. It produces certain hormones that act on the uterus. Then you need your womb or the uterus, the endometrial lining, which generates, for want of a better word, or proliferates. Then if no baby comes in, the hormones go down again, and then you menstruate. So if we are taking out the uterus, then there is nothing to proliferate or no endometrium to germinate for you to menstruate. However, if you did a subtotal hysterectomy, because there's something called subtotal hysterectomy, depending on the level that the hysterectomy was done, if there's still some viable endometrial tissue, then that woman may be spotting along the way during the menstrual period, especially if she's not yet menopausal or postmenopausal. There's still a possibility of she spotting along the way. But if the entire uterus was removed, or the uterus was removed to the point that there is no remnant of viable endometrium, then it is not possible for her to menstruate.
All right, thank you very much. Thank you very much. At this point, we've come almost to the end. If there are no more questions, thank you very much, Dr. Juve, Juventus Atta. Thank you. Please, what will be your final words to us all?
So my final word is that cesarean section saves lives. And when indicated and it is offered, we must all know that it's not because the doctor loves operating or the team likes opening the woman up. In fact, it is a difficult thing, but it's only because it saves lives. However, the cesarean section rate is going so high, and cesarean section is associated with so many complications, some of which may be very dire. And for that matter, the issue coming up, which it's sometimes distressing for me that I find that some of these things is actually clinicians who push it, nurses, midwives, other cadres of medical staff who push it, that have a cesarean section, have a cesarean section. We should know that cesarean sections are not without complications. In fact, it is fraught with a lot of complications if not done well. That again, I do not want to scare anyone that cesarean section is complications. I'm saying medical practice has improved so much that most of these complications do not happen. Are you getting me? So yes, it is very safe in our current practice. Yes, when indicated, it is very necessary, but it shouldn't be something that we should be pushing so much for. Because WHO says that when you cross the 15% threshold, the benefits is less than the risks. On that note, I would like to thank you very much for this opportunity, and I'd like to thank your audience. And I'm so impressed with the kind of questions that they ask. And I hope that this will inform our clinical decisions and help reduce the burden of maternal mortality. Thank you very, very much.
Thank you very much, Dr. Juventus, as a specialist obstetrician gynecologist who's sacrificed his time to share this very accurate medical knowledge with all of us. Of course, this is for us and everyone else that we can get to educate, to help reduce the level of misinformation. That some of the things that you get to hear that result in maternal mortality, it's not something that we should be perpetuating. So thank you very much, all of us online. Please join me, say a big thank you to Dr. Juventus Arthur for sharing such with us all. Thank you very much. Every one of us on the call is saying thank you, Dr. Juventus Arthur. We appreciate your time and we are grateful for the sacrifice. Thank you very much. And for all of us, all the audience on Zoom and on YouTube, I'm glad to have come your way once again. As usual, the recording will be made available on the YouTube channel. I'm sharing again the link in the Zoom chat. For those of us on Zoom, you can subscribe and benefit from this particular one and previous ones, and of course, be on standby for subsequent presentations as well. Once again, it's been a plum pleasing pleasure serving you all.